Hello guys, welcome to Medicate Hub. After so long back, we're putting a new interesting videos about how APR will prevent ARDS. You have any idea? Please comment in comment sections, okay? So today we are seeing how APR will prevent ARDS. So we'll go inside a video. So today what we are all seeing means what is ARDS, what is the risk of mechanical ventilations, introduction of APRV and APRV, how it will be a lung protections and what is a preventive approach and what is the lip score and what are clinical evidence of APRV and what are the challenges if we start APRV mode. Okay, so first we'll go into the first one. What is ARDS? So introduction of ARDS. So we all know what is ARDS and all. So it is one of the life-threatening conditions. Okay. So what is this characteristics? It will be a poor oxygenations and non-compliant, or it will be a stiff lung. It will be right. No. So in this ARDS, that's associated with of capillary endothelial injury and diffuse alveolar damage. So this and all will be associated for ARDS also. So we see the Berlin definitions. So we know all that. So ARDS is one of acute diffuse and inflammatory lung injury. So due to this, there is an increase of pulmonary vasculature and increase of lung weight, and it will be loss of aerated tissues and all. Okay. So we know all about ARDS and what are the classifications and Berlin definitions. So I not go deeper inside that. So we'll see most of it will cover only a APRV mode. Okay. So in this you can see how ARDS will be happening.
In ischemic and inflammatory insults, capillaries can leak, leading to organ failure. In the lungs, this is called Acute Respiratory Distress Syndrome, ARDS. ARDS can be a result of pneumonia, sepsis, influenza, major trauma, or surgery. Due to endothelial barrier dysfunction in ARDS, alveoli are filled with protein-rich fluid and leukocytes. The lung cannot oxygenate blood and other organs are at risk of hypoxia. Dying cells in hypoxemic organs release excess amounts of pro-inflammatory ATP. Excess ATP leads to a systemic aggravated inflammatory cascade, SIRS, and further damages the endothelial barrier. CD73 is the key enzyme that converts pro-inflammatory ATP to anti-inflammatory adenosine to maintain the endothelial barrier. CD73 is expressed at low levels in ARDS. Adenosine inhibits leukocyte migration, tightens the junctions between endothelial cells, and increases pumping of fluid from alveoli. Excessive endothelial leakage is a hallmark of ARDS. Understanding the mechanisms behind this will be key in treating ARDS, which currently has no drug treatment. For more information, please visit www.farron.com.
So guys, I think you get understanding due to endothelial damage, you can get ARDS. About that only they said. So I'll move on. So here you can see what is the ARDS mortality rate. So this one research, every year they're taking 1 lakh persons of ARDS patients. So if you see, there will be a peak will be starts from the 2001, sorry, 2002 to 2000. Oh, that's a little bit peak. Again, it will be peak on 2005. And later it is coming to 2019 to 2022 because that's a COVID pandemic times. Okay. So that time there's a more patients are getting a ARDS. There's a more peak times of the ARDS. And now we will see the same that research. So at what age are patients getting ARDS more and on hospital how it will be more, how it is the hospital mortality also. So it will be little bit increase in 0 to 9 and after its peak it starts from 40 to 49 age and greater than 90. These are places they can get a chance of ARDS. And if you see hospital mortality, there will be peak from 0 to 9 to 20 to 20. It's a peak range of mortality of ARDS patients. And if it's, and also its peak is starting from 40 to 49, and it will be going above only. So in that also, in this age also, they get a high mortality, hospital mortality rate in ARDS patients. So now you will see the risk of mechanical ventilation. So if it is a APRV or any other mode, if we not maintain a good ventilation, we're not giving a good ventilations, we can get biotrauma, atelectrauma, biotrauma, oxygen toxicity, and patient ventricular asynchronous. So this and all can happen. No, this and all the risk of ventilations. Next, we'll come to the main topic, introductions of APRV. So we know APRV means it's airway pressure released ventilations. So this APRV was initially described by the Stock and Downs in 1987. So as at that time, it's a continuous positive airway pressure, but there is an intermittent release phase is there. Okay. So this APRV will be applied like a CPAP. So that means a PA. So it's a prolonged time T high. And if you maintain adequate lung volume and alveolar recruitment with a time cycle release phase at lower set pressure is pressure low. And in a short time of period, they will do. So it's a time low. So where most of the ventilation will happen. So due to that ventilation and CO2 removal can occur. So if you see this graph, it's at P high and P low. Okay. And this at T high. So prolonged time intervals is there, no? So it's a Ti, and it's during expression if you see means there's a short of T low. So this APR will be doing a spontaneous breathing only. Okay. So we will come to the initial parameters, what are the initial parameters, and how we and all set. Okay. First there's a four initial parameters. Okay. There's a four initial parameters. One is P high, P low, T high, T low, and all. So in PA, if we see means we can set as a 20 to 30 centimeter H2. We can go up to 35 also for obesity patient, but more than 25, no need to avoid more than 35. So what is the purpose of PA means? It will be maintain a lung recruitment and improve your oxygenation. Okay. So what if we did means what under key points means we can set up to 5 centimeter above map or use a plateau pressure also. But avoid 30 to 35 greater than 30 to 35 centimeter. So we can set a 5 centimeter above map or use plateau pressure. Map means mean airway pressure. Okay. So you want to avoid more than 30 to 35 centimeter H2O. Next we come to the P low. So in P low we can start from 0 also. We can go up to 5 centimeter H2O. What is this purpose of P low means? It promotes the autopip during expirations. Okay. And we come to the T high. So it's Ti. So we can set up to 4 seconds. And also we can adjust according to your oxygenation, based on your oxygenation also. Okay. What is purpose of Ti means? It control the inspiratory time and it will increase the mean airway pressure. Okay. So if we keep a longer TMI, there will be better oxygenation. If you keep too long, it will be reduce the CO2 clearance also. And we will come to the T low. So in T low, if you see means we can set 0.2 to 0.8 seconds. How we will set means we have a cutoff flow at 50 to 75% of peak expiratory flow. Okay. So what is this purpose of T low? If you see means we can manage the release auto people also. Okay. If most critical settings, if we keep a too long of T low means there will be derecruitment will happen. If we keep too short also air trapping will happen. Okay. So according to that we want to set the T low. Next, we'll see the APRV adjustments. So what and all condition, what and all adjustment if we did means what and all goal we can get. Okay. First, we see the hypercapnia. So hypercapnia means we know there will be an increase of CO2 also. So this time, in this hypercapnia condition, we want to decrease your patient's sedations. Okay. And we want to promote their spontaneous breathing. Okay. So we can increase a PA like 1 to 2 centimeter, but it want to be less than up to 35 will go. Okay, more than 35, no need. Okay. So, increase a P high by 1 to 2 centimeter of H2O. Up to 35 we will go, okay. And we want to reduce the TI also. So if you reduce a TA, there will be release of frequency, increase in release frequency will happen, okay. Next, if we decrease PLO, we want to decrease a PLO. So if it is greater than 0 means you can reduce, if 0 means no need of that. And you want to increase a TLO slightly. So before only said we want to see the end expiratory flow if it is greater than 50% of PEF. Okay. If this settings and all, if we did means we can increase the CO2 removal via minute ventilations. Okay. And we'll go to the second one, hypoxemia. So hypoxia means there will be decrease of O2. Okay. So in this time we can make a settings decrease a TLO. So if it is end expiratory flow is less than 50% of PEF or at ideal volume is greater than 8 ml per kg. Okay. And we can increase a TA 0.5 to 1 seconds. Stay up to 30 to 35 only. Okay. So in this range, we can increase the mean airway pressure. So therefore, there will be increase of oxygenation also. And we will come to hypocapnia, decrease of CO2. So in this time, we can make a settings like decrease PI. So if able for oxygenation, okay. And we can decrease a T high also. So that time there will be decrease of minute ventilations, okay. So CO2 removal will be a little bit less. So we can make into a normal patient, okay. Next, we'll see the what and all advantage and disadvantage of APRVs. So we'll see the what is advantagement. Okay, what is the advantage means there will be alveolar recruitment will be there and improve oxygenation will be there, and we can make a spontaneous breathing also. So due to this APRV, there will be reductions of left ventricular transmural pressure. So therefore, there will be a reduction of left ventricular afterload. Okay. Next, we can make a lung protective effect and we can better ventilation depend upon the areas, dependent areas, and we can lower the sedations so to allow a spontaneous breathing. So this and all the advantage of APRV. What is the disadvantage means? There will be a risk of trauma. So due to increase of transpulmonary pressure, okay. And also increase of work of breathing due to a spontaneous breathing, okay. And also a increase of energy expansion due to spontaneous breathing. But there is a worsening of air leak will be there. And there will be an increase of right ventricular afterload. It worsening the pulmonary hypertension also. And there's a reduction of right ventricular venous returns, okay. So maybe this right ventricular venous return, there will worsen the intracranial hypertension, may worsen cardiac output in hypovolemia. And there will be risk of dynamic hyperinflation. Risk of dynamic hyperinflation. So this and all the disadvantage of APR. I think you will be understand, I think. So okay, we will move on. So now we'll see how APR will, if in APR, how APR will be lung protections, okay. So first we'll see the APRV in application of APRV in ARDS patients. Okay. So before only we know ARDS is one of the severe condition with high mortality. So it will be increase of alveolar capillary permeability also. Okay. So the goal want to be for us means it want to be lung protective ventilation. So you'll open the lung and keep it open. Okay. So by what and all we can open the lung means recruitment manner. So it can be reopen a collapsed alveoli. And if we keep a high PP, it will be prevent the repeating collapsing of alveoli and the reopening. And this open lung strategy is there, no? So it will be improve the oxygenation and in the shorten the hospital stay through it shorten the hospital stay, though it doesn't reduce a mortality. So when this APRV concept will be fully different, okay. So this time we can use a prolonged high pressure phase, that means PI. So with continuously recruit the alveoli also, okay. And allowing a collateral ventilation to stabilize and evenly distribute the air in the lungs. And if we keep using a very short TLO, it will maintain auto PIP. So which prevent the alveolar collapse by allowing a partial lung deflations, okay. But this make a effective and potential life-saving ventilation strategy for ARDS patients, maintaining a stable and open lung throughout the breathing cycles also. So we will go to the APRV in adults with acute lung injury or ARDS. Okay. So during some initial stages, the APRV are not used as a primary ventilation mode. Okay. They are considered as the alternative approach of patients in ALI and ARDS. refract to conventional mechanical ventilations. Okay. So, according to some studies, they are comparing the APRV and conventional mode with the patients of ALA and APRV. Sorry, ARDS. Okay. So, most some studies are crossover that they are switching a assist control or synchronous SIME mode to APRV as a randomized control trials with a sample of 22 to 138 patients. Okay. So in different studies, they use a different settings which indicates constancy and complexity of APRV. But most of the studies, they reported APRV could improve the oxygenation and it compared to other modes. Okay. So what under APRV it showed means it will be improve oxygenation, it will improve the hemodynamic and respiratory system compliance, and it reduce a peak inspiratory pressure and reduce a airway pressure and P-plate. But there is a no need of sedations and paralysis. Okay. But no studies they prove that APRV could improve the mortality of patients with ARDS. Okay. But it will be associated with the reductions of incentive ICU care stays and it reduce the progressions of ECMO and all. API in APRV adults with prone position. We can do in APRV with prone position also. So this research is combined with APRV and prone positions. They had limited in 2 case reports and 1 prospective randomized control trials. Okay. So this studies reports are that combines a 2 mortality, it results the greater improvement in oxygenation. Okay. Warplow et al. So first he discovered that APR with combine of prone positions is feasible in ARDS. Okay. So the prospective of randomized control conducted 2 years later, they confirmed their results. Lee et al. So he reported the 5 ARDS cases with APRV and prone positions were used to found API safely to used in prone positions also. So there will be improve oxygenation. And Rose et al. So she reported 8 cases of ARDS under ECMO also. So he demonstrated the moderate SBA with APRV as a feasible which maintain the tidal volume in ultra protective range without any complaints after ECMO also. So now we will come to the preemptive approach. What and all things if we did means we can prevent the ARDS. First, so we can make sure the risk factors, high lips and yearly APRV lung protective strategy and we can prevent ARDS. What and all risk factors if you see means sepsis, pneumonia, aspirations, trauma, shock, this and all the risk factors. Okay. And eye lips. So about these lips, I'll say you later. Okay. So normally a lip score is if it is greater than 4 means they'll say a high sensitive patient getting ARDS also. So okay. So now we know that what are the risk factors and what are the high lips. So how, if it is great, if a patient getting more than 4 of a lips, you can get a chance of ARDS and all. So if we have a idea this patient is getting a chance of ARDS, okay, we can start yearly APR mode. It's a better choice for ARDS patients and we can preventive of APR in ventilator settings also. And lung protective strategy. So this strategy is aimed to we want to minimize the lung injury by preventing a over distension and reducing alveolar collapse and maintaining adequate oxygenation. Okay. So if we did this and all means we can prevent the ARDS also. Okay. You just watch this video.
If you consider that it has been shown that 10% of all admitted ICU patients develop an acute respiratory distress syndrome ARDS, and their mortality is, depending on the severity, between 35 and 45%, then I'm really worried. This shows that everything necessary to prevent ARDS should be done. Since it is difficult to reduce the mortality of established ARDS, it is important to shift from treatment to prevention. Wouldn't it be good if there is something like a recipe that counteracts the development of ARDS? It's recruitment of the lung, specifically of dependent compartments. While recruitment is affected by time and pressure, the elevated mean airway pressure contributes to the recruitment of slow recruitable compartments of the lung. Well, it's not just one single aspect. There are more ingredients. Alveoli must be kept open and prevented from overdistension and collapse. It is important to prevent stress and strain caused by atelectasis and overdistension. which means carefully ventilating the healthy compartments of the lung while preventing collapse of alveoli. Ventilation therapy should ideally support spontaneous breathing. But how should this be done altogether? APRV. This is short for Airway Pressure Release Ventilation. This has been described first by Downs. It implies ventilation on 2 different CPAP levels and supports unrestricted spontaneous breathing at both levels. But is that really safe? Well, it stabilizes alveoli ventilation and prevents further development of edema. APRV facilitates spontaneous breathing by delivering continuous positive airway pressure and augments ventilation with brief pressure releases to support CO2 removal.
I think you guys understand what is APRV and all. Let's move into the lips. It's a prediction of the ARDS risk. Next we'll go to the lips. Okay. So lips means it is a lung injury protection score. Okay. So it will be used to predict the which patients are getting high chance of ARDS. Okay. So this lips is coming with the 3 factors. Okay. One is predisposing conditions, one is other clinical data and risk modifiers. Okay. So if you see this is a lips scores. Okay. And according to the risk factor, there will be a points also. Okay. So first we'll see the predisposing condition. In predisposing condition, you can see shock, aspiration, sepsis, pneumonia and all. And we come to high risk surgery. In high risk surgery, there will be orthopedic spine, acute abdomen, cardiac and aortic vascular. And we'll go to the high risk trauma. So there's the traumatic brain injury, smoke inhalations, near drowning, lung contusions and multiple fractures also. And we'll go risk modifiers, alcohol abuse and obesity if BMI is greater than 30 and hyperalbuminemia and chemotherapy and FiO2 is greater than 0.35. That means greater than 4 liter per minute and tachypnea respiratory rate is greater than 30 and SpO2 of less than 95% and acidosis when ABG APH is less than 7.35 and diabetes mellitus. So according to this, they gave a points also. Okay. For example, if you see, if the patient with a history of alcohol abuse with septic shock from pneumonia recurring FiO2 of greater than 0.35, that means greater than 4 liter per minute in the emergency room. Okay. So in this, if you see, means they gave sepsis is there for that patient and shock is there and pneumonia is there and the patient was alcohol abuse and there will be FiO2 of greater than 0.35. So if you see first is sepsis, so we can see the point of sepsis is 1. Okay, 1 plus next we go to the shock. For shock, if the point is 2 plus 2. Okay. Next pneumonia. So if you see pneumonia, there will be point of 1.5. Okay. Next plus 1.5. And alcohol abuse. So if you see the alcohol abuse, the point is 1 plus and the FiO2 is greater than 0.35. So for FiO2 is greater than 0.35, you can see a point of 2. If you add this and all, there will be a 7.5. So for this patient, there will be a higher chance of getting ARDS. Okay. Next, second example, if you see, if a motor vehicle accident with traumatic brain injury, lung condition, and shock record FiO2 is greater than 0.35. Okay. So here you can see a traumatic brain injury they gave and lung contusion is there and shock is there and FiO2 of greater than 0.35. Okay. So now you see it's a traumatic brain injury. For traumatic brain injury, there will be a point of 2. Okay. Next, lung contusion. So lung contusion they gave a point of 1.5. Okay. Next, we'll see the shock. Shock already, there are point of 2. Okay. Next, FiO2 is greater than 0.35. So, we know that point is 2. If you add this another, same 7.5. So, you say this patient, you say, you come and now you comment me, this patient will get a higher chance of ARDS. Next, we will go to the third example. If the patient history of diabetes mellitus and urosepsis with shock, okay. So already they gave a patient as sepsis and shock is there and diabetes mellitus is there, okay. So for sepsis, a point is 1 and shock a point is 2, okay. And diabetes mellitus, a point is -1, okay. If you calculate this means the answer is 2. Okay, for this you comment me if a patient is getting a higher chance or lower chance of ARDS, okay. So this is a lip score. Next we'll go to the clinical evidence, okay. So this clinical evidence by a Yongfang Zhou, okay. So this research is done on a West China hospital in 2015 to 2016, okay. So in this they are doing a animal study suggested updated APRV settings, okay. Lung recruitment and oxygenation while reducing a lung injury without harming circulation, without harming a circulations, okay. So this test they use in yearly use of API and ARDS patients. So could it reduce the need of mechanical ventilation compared to standard low tidal volume ventilation, okay. So they took 138 patients with ARDS. That patients are ventilated is less than 48 hours, okay. So they randomized into as a APRV group and low tidal volume group. So APRV group, there's a number of 71 patients is there. In low tidal volume group, there is a patient number of 67, okay. So in APRV, this what settings they did means there will be PI will be last P plus, that means maximum 30 centimeter H2, okay. And P low if they kept as a 5 centimeter H2, okay. And T low they set a terminate at greater than or equal to 50% of peak expiratory flow and respirate of 10 to 14 breaths per minute, okay. And for the low tidal volume ventilation, they followed as a ARDS net protocols. There will be 6 ml per kg tidal volume and P plat is less than 30 centimeters H2 and PEEP and FiO2. So optomy PEEP and FiO2 and all they kept. Next we'll see the key results, okay. So the ventilator free days are 20 days. So this 28 days is the no. When the patient is started ventilator, no, from that day onwards it will be counting, okay. Total 28 days, okay. In the 28 days, the APRV group patients is the no. So they are free from ventilator for 19 days. They are free from. In the 20 days, they will be ventilator free is 19 days, okay. And low tidal volume group is so in this 28 days, the patients are ventilator free days is only 2 days, okay. This APR group, there will be a shorten of ICU stay and ICU mortality is tended lower than APRV also, okay. So the APRV patient get a better oxygenation and compliance and lower P plat and that will be reduced sedation in the first week only they reduce the sedations and all, okay. So we go to the conclusions. So yearly APR in ERS, it will improve the lung mechanics and outcomes visas of low tidal ventilation, okay. So in fewer days only the ventilator there will be better oxygenation, shorten ICU stays and potentially refining ARDS ventilation strategies. So if you see this A and B, so this is a APRV mode of lung, this is a cross sections of the APRV mode of lung, okay. And C and D, so this is a low tidal volume lung and that's a cross section of low tidal volume lung, okay. So first you see picture A, the APRV mode ventilation is done. No, APRV mode ventilation. No. So there will be normal pink and homogeneous and inflated lung tissues. There is no evidence of inflammation or atelectasis. Okay. So if you there will be cross sections of B, there is also APRV only. Okay. So there is no bronchial or septal edema will be there. Okay. Next we come to the C, it's a low tidal volume of whole lung, okay. So in that you can see a prominently atelected with heterogeneous parenchymal inflammation will be there, okay. And in cross section if you see means there will be a gel-like edema will be there, intraocular septal with airway edema is there. So this and all, so you can see the white patches like edema and all. Next we'll see the what and all challenges of APRV. So for APR until now there is no standardized settings. So we depend upon patients we can set, okay. And that's if we not manage APR well means There will be risk of biotrauma and biotrauma, and difficult to monitor a tidal volume also, and CO2 retention will be there, hypercapnia will be there. So for this APRV, we require a skilled management persons and potentially hemodynamic effects. It's not suitable for all patients, only a ARDS patient can keep. And there will be limited high-level evidence also. So due to this reference, I will make this PPT and all. So you have any questions, just come on me. I'll reply your questions, okay? Okay, thank you guys. And this PPT, there is some two videos is there. So the first video will be credited to Paron Paramedicals, and the second video credits goes to the Dragger Ventilation. Thanks for sharing the videos to me. Okay, thank you guys. We will see in the next new video. Okay, thank you.